Good morning. Before we start, I want to actually say welcome today to Lourdes Corman. She was the internal medicine program director before Dr. Barbara Casper, and very, very famous, good teacher here. And she's sitting next to Stuart. Stuart, how many years have you been on faculty? He says 200. If you have been on faculty here more than 20 years, raise your hand, or close to 20. Raise your hands. Okay. Okay. So this is going to also apply today to our speaker. There's something about Louisville, no matter where you came from, you come here and it's going to stick. So remember that, residents, if you guys come here, it's going to stick because you'll learn to love Louisville. It is my pleasure today to introduce our guest speaker from the Department of Neurology. Dr. Remmel would be here to introduce him, but she has grand rounds, neurology grand rounds. What I can tell you about Michael is probably everybody in the room has had to refer a patient or be a patient in his headache clinic, which he is most proud of, that he has developed here and has been the director of for 17 years, back before there were even headache fellowships. So one of his dreams is to have a headache fellowship. He received even though he's from Arkansas, he received his undergraduate degree and graduated cum laude from Southwestern in Texas. And then he went on and did his medical school and residency. And he's a professor of medicine and pediatrics, and he tells me that makes the transition much easier. So it's not, 18, go see adult now. He can actually continue to take care of his patients. Great welcome. Thank you very much for being here and teaching us everything about migraines. I noticed everyone got coffee this morning. That's one thing you can do. I do remember that.
Good morning. So we're going to talk about migraine. So migraine is the most common headache disorder that we'll see in the healthcare field. The most common headache disorder in the general population, of course, is tension type headache, but there's not much research or new drugs or interest about that. We're going to talk about new drug therapies and the treatment of migraine, a rapidly shifting paradigm. So these are my disclosures on several speakers' groups. I think almost everything I'm going to talk about this morning is going to be on label. But if it's something off label, I'll point that out. And then our objective is to overview the monoclonal antibodies to CGRP, which is a class of medications in prevention of migraine, and then briefly discuss Ditans and Gepants. So these are new drug classes that are going to be coming out this year, basically, which have recently received either FDA approval or NDA, new drug application, acceptance by the FDA for acute relief of migraine. So both acute and preventive treatments for migraine is what we're going to be talking about. So new drug therapies, basically the monoclonal antibodies, these are for prevention. And these are arenumab, fremanezumab, and galcanezumab. So it's taken me a while to kind of get with the lingo. But received FDA approval now 2 years ago, right? So the first one received FDA approval in May of 2018. So we're coming up on 2 years for the first of the monoclonal antibodies to CGRP. I'm sure you've seen patients that are on these drugs. Ditan, there's one basically that has received a new drug application and actually FDA approval for acute treatment, and that is though pending classification by the DEA for probably being a Schedule 5 for somewhat diffuse reasons. Dizziness, I think, was the main thing that tipped it over the scale. And then Gepants, two of which are either received a new drug application or pending FDA approval this year in 2020. Our outcome then is to hopefully improve the management of individuals with migraine utilizing newer therapies. So we'll look at epidemiology, basics on migraine pathophysiology, and then definitions according to the ICHD-3. The ICHD-3 is International Classification of Headache Disorders, 3rd edition. So some of us are old enough to remember the first edition, which is 1988. But that's kind of a way to classify headache disorders. So if you're on call or stuck somewhere, you can always get to a computer and Google ICHD3 and find the classification scheme and the criteria for different headache disorders. The migraine is a primary headache disorder, not a secondary headache disorder. And then we're going to talk about monoclonal antibodies, Gepants, Ditans, and then summary and conclusion. The migraine affects 15 to 18% of the general world population, with women affected about 3 to 1 more so than men. Migraine is a highly prevalent, severe, disabling condition, neurologic condition with significant unmet needs for effective therapies, both preventive and acute, basically. And CGRP is a key component in the underlying pathophysiology of migraine, and we'll examine that a little bit further. And then research focused on targeting CGRP for headache treatment has led to the development of the entirely new classes of medications, the Gepants and the monoclonal antibodies to CGRP for both acute and preventive treatment. And then there's a third class, which is the Ditans, are developed to target the 5-HT1F receptor to provide acute treatment without the vasoconstrictive effects. So you'll remember that Triptans are 5-HT1B and 1D receptor subtype agonists, serotonin receptor subtype agonists. 5-HT1F is another receptor, but not involved with vasoconstriction. So just to review some basic definitions, so migraine without aura is 5 previous attacks, each between 4 and 72 hours. 2 out of 4, so moderate to severe unilateral pulsatile, either worse with or causing avoidance of physical activity, and then 1 out of 2, either both light and sound sensitivity or nausea and or vomiting. And then not better accounted for by another ICHD3 diagnosis. And then chronic migraine is 15 or more days per month of headache for more than 3 months, 8 of which, more than half of which, meet diagnostic criteria for migraine. Now, it's often a little bit hard to sort of diagnose in the sense of, you're always wanting a patient to be tracking their own outcome, right? Because it's a subjective problem. So I recommend apps like Migraine Buddy and things like that to kind of track their headaches and then give the patients on a learning curve. So they're giving me a report of how frequent their headaches are and that sort of thing, but may not keep all the detail to tell you that 8 out of 15 of them met criteria for migraine, that sort of thing. So we're going to be talking mostly about acute and chronic migraine. So migraine, as we know, can transform back and forth between chronic and episodic migraine, and we see that, as Dr. Kruger mentioned, I've been here 17 years, so I have lots and lots of patients who transform back and forth between episodic and chronic migraine. And so my goal is probably an unrealistic goal to cure migraine. As far as we know, it's genetic, but my goal is typically to try to get a person from chronic migraine back to episodic migraine, which is a much more manageable condition, and then that often can be managed within the purview of the primary care physician, for example. So as I mentioned, migraine can transform back and forth. So prevention is multifaceted and includes behavioral management, lifestyle modifications, migraine attack trigger, identification and avoidance, and then avoidance of risk factors for development of more frequent migraine attacks. And when indicated, medications or nutraceuticals or neurostimulation rarely, and then other behavioral therapies in particular. So this is kind of our objective for preventive migraine. I won't read the whole slide, but essentially our goal is sort of prevention of migraine and improvement of overall quality of life. So the challenges remain in the use of a preventive therapy. So about 40% of migraine patients could benefit from a preventive therapy, but less than about 15% are actually using a preventive therapy. 80% of patients who initiated a trial of an oral migraine preventive are no longer taking it after about 12 months or so. And then there's significant problems with the older preventives. So as most of you know, the migraine preventives are medications that are FDA approved for something else, but we use them because there's evidence for prevention of migraine versus placebo. So the greater than 50% responder rate for all previously available oral migraine preventives is about 45%, which is not great. On the optimal dose and on medication for at least 2 or 3 months, likelihood of having a greater than 50% reduction in headache days is less than about a coin flip. And problems currently include things like lack of efficacy, specificity, side effects, adverse events, poor adherence and significant time to achieve benefit. So typically, we tell a patient to give at least 3 to 4 months on a preventive before it's decided to change to a different, that it's not working, basically. Obviously, unless there are adverse events or side effects. So these are sort of guidelines that were developed by consensus of a number of national organizations on when do you start a preventive treatment. So basically 3 or more moderate to severe headache days per month that cause functional impairment and not consistently responsive to acute treatment, or at least 6 to 8 headache days per month, even if acute medications are effective, contraindications to acute migraine treatments, and particularly bothersome symptoms, even if their attacks are infrequent. So, I have truck drivers, for example, that have a hemianopsia, when they have a migraine, if they have one every other month or something, that may push me in the direction of putting them on a preventive strategy because of the degree of disability associated with the attack of migraine. And then the other sort of variable that we have to deal with is medication overuse headaches. So the concept being that individuals who are using medications that are typically approved or advised for acute treatment of migraine that are overusing that medication. We know that there's a association with chronic migraine and medication overuse. So triptans, simple analgesics, combination medications, used to be Fioricet, but over-the-counter combinations like Excedrin migraine, right? So the caffeine, acetaminophen, aspirin, just put it all together. I think so. Medication overuse is what we see a lot of. But preventive treatments, prior to 2018, what we had is we can sort of look at the list. Medications, so lifestyle and behavior is always a part of migraine treatment, but then, amine modulators or anticonvulsants, it's typically anti-medicines, right? Antihypertensives, anticonvulsants, antidepressants. And there are a few supplements or nutraceuticals, that have been demonstrated to be effective for prevention. This is a very busy slide with very small print, so I'm actually going to just gloss over that one. But that kind of details the complexity and side effects of medications that we have available. But this is a slide just kind of showing us what the pathophysiology of migraine involves. So it's initiated probably by peripheral activation of the trigeminal vascular system. So sort of back in the day, in the 50s and 60s, it was thought that migraine was purely vascular, right? So there's vasoconstriction and vasodilatation. That's what gave you the pulsatile sensation of having migraine. But now we incorporate a concept of an inflammatory mediator, and then also probably some vasoactive component. But peripherally, you have sensitization, you have sensory receptors in the dura and surrounding blood vessels. But then you have feedback through either the trigeminal or sphenopalatine ganglion or both. And then feedback to the brainstem, and then more rostrally, and that's how you perceive pain. So a number of vital kind of neurologic structures are involved, so in the brainstem and in the thalamus, which is basically the relay station for sensory afferents. So CGRP is a potent vasodilator, a mast cell degranulator, mediator of inflammation, modulates transmission of pain signals from meninges to the CNS. Is released in the trigeminal ganglion, is stimulated. Various studies have been done. And I'll show you a slide of kind of timeline, but administration triggers headaches in patients who have a history of migraine. Levels are significantly, persistently elevated in patients with chronic migraine, even in between attacks. And then the release is suppressed by anti-migraine agents such as the triptans. The triptans are what we've had to this point, the elatriptan, et cetera. Those are triptans. But what are the pain-sensitive structures in the head? Well, the meninges, so the dura, the venous structures, tributaries, the various specific cranial nerves, so 5, 9, and 10, basically cranial nerves, and then scalp and superficial structures, and then vascular structures, so dural arteries. So this is, my danger zone per se is, is this a TIA, for example, with a headache that may seem like migraine, or is this something else? Or is this just migraine? But we see that CGRP plays a vital role in this concept of sterile inflammation and is a inflammatory mediator that's been identified a number of years ago. And this is just another kind of cartoon of the same thing, but kind of three major points where CGRP may play a role both peripherally and centrally. Again, looking at CGRP, but this illustration also points out where the 5-HT1F receptor is, which is more centrally. The 1B and 1D are more, the 1B in particular is more in the peripheral nerve cell, and then surrounding blood vessels is the 5-HT1D. So we always are concerned about triptans in the presence of cardiovascular disease, and they're contraindicated in that situation. Sorry, this is my wife. We live on her farm, and she goes out to feed, and Nicole, they ask her to text me when she goes out and comes back in. So this is an illustration of where CGRP is present, again, sort of surrounding the dura, dorsal raphe, locus coeruleus, superior salivatory nucleus, and then trigeminal ganglion. These are all structures that are involved in migraine attack. So the monoclonal antibodies are big molecules. They probably don't cross the blood. They, in fact, don't cross the blood-brain barrier, and they're eliminated through the reticular endothelial system. So far, there's no risk for liver toxicity, which we'll talk about, was a previous concern for the Gepants, which have been underdeveloped for a number of years. But because they have demonstrated to be effective, it's likely that they're more peripherally active, the monoclonal antibodies being larger molecules. And that's probably sufficient to prevent attacks of migraine. This is just nomenclature, and I think you guys probably know this already from other monoclonal antibodies in other territories. But this is a timeline illustration of development of CGRP and knowledge of CGRP as a active inflammatory mediator in the pathogenesis of migraine. So back even in 1983, it began to be determined that CGRP was a potential target, and then various drugs have been under development. The sort of first generation Gepants, I'll say, we were a site here for placebo-controlled trials for prevention, and were fraught with liver enzyme elevations. So those studies were halted, and that was in the early to mid 2000s, which seems like yesterday. But so the newer drugs are different molecules and are not so far associated with significant hepatotoxicity, and we'll talk about those. But this is a Prp antagonists looking at a variety of different studies. Again, early on, the ones where there's an illustration of liver and where there's a stop has to do with the liver enzyme elevations. And those are studied. But then there emerged two different molecules that are continuing to undergo investigation and pending release, basically, because they have been shown to be superior to placebo and without significant liver enzyme elevations. So that's kind of the monoclonal antibodies to CGRP that have been approved so far are highlighted. So using generic names, arenumab, galcanezumab, and fremanezumab, three different drugs. The fourth one, the difference with the fourth one is that it's going to be administered IV, and that's thought to be going to be released. I think it's received an NDA and not yet FDA approved, but it's probably going to be released in the second or third quarter of this year. Interestingly, has onset of action for prevention of migraine in a day or two in some patients. So lots of excitement about giving something IV. But the ones that we have had since 2018 and are using are subcutaneous and can be given most cases monthly. There's one that can be given quarterly and has been demonstrated to be equally effective in giving it quarterly. Personally, I don't find a whole lot of benefit in my patients to give something quarterly versus monthly. I think if you're talking about your healthcare, you should be thinking about it at least monthly, if not daily or moment to moment. But if you push something out quarterly, in my mind, that suggests that the patient may be less likely to be compliant with remembering that. But the 3 out of 4 have the target of the actual neuropeptide of CGRP. The 4th one targets the receptor. Either way, it binds and disrupts the interaction between CGRP and its receptor. So it's thought that the mechanism, even though the target may be slightly different, the mechanism is probably the same in terms of disrupting the interaction of the two. So as I mentioned, narinumab, fremanezumab, galcanezumab, and these go by trade names of Aimovig, Ajovy, and Emgality. And then eptinezumab was initially an Alder drug, is now a Lundbeck drug. Lundbeck bought Alder last month. Mentioned it's pretty rapidly changing paradigm. So pending FDA approval. I'm going to skip. So this is just illustrating the monoclonal antibodies, the 50% responder rate for prevention of migraine in different paradigms, but prospective randomized controlled trials versus placebo. And you can see that they all are effective in terms of 50% responder rate. So 50% responder rate, what does that mean? The monthly migraine days is the biggest outcome measure, or the primary outcome measure. And if you go from 28 days a month of migraine to 14 days a month, after a few months, then you're better off in terms of migraine being pretty disabling for those that are having attacks. And this is kind of similar, just summary sort of data having to do with the 4 different monoclonal antibodies. Different concentrations are but all. And this is even in patients with chronic migraine, sort of thought to be a more refractory segment of the population, if you will. And by the way, about 1 to 2% of the population has a chronic daily headache syndrome, so that's what keeps us hopping, right? And just different paradigms, again, looking at the 50% responder rate, but in the more refractory chronic migraine population, and significant efficacy over placebo. And then versus on the right, Botox and topiramate, which have a pretty high placebo rate as well. Then arinumab, even in patients with prior preventive treatment failures, be effective. So patients 1 to 2 prior preventive treatments where they failed either due to lack of efficacy or adverse events or side effects, still will respond to the monoclonal antibodies. And then how about after a year? What does efficacy look like after a year? And this is sort of reduction in numbers of monthly migraine days over a year for 2 different studies graph. And then what about other efficacy outcomes? So in the chronic migraine study, 50% baseline versus months 1 to 3, and then medication overuse minus opioids. So you recruit a population, and in chronic migraine, chronic migraine in particular, you're going to have a lot of patients who have medication overuse. And those are patients who, don't pry my cold dead hands off my Tylenol or whatever. And so they're thought to be more refractory to a preventive type strategy, but even in the context of medication overuse, these drugs can be effective. And then even in a history of aura, so it's not necessarily thought that aura is more refractory with that particular population study. Then other things like anxiety and depression, drugs are still effective, and then the previous Topamax or Botox. Side effects of the CGRP monoclonal antibodies. Again, we're talking about prevention of migraine, so reduction of frequency, severity, or duration. So safety, so no changes in blood pressure, heart rate, or EKG, or any laboratory evidence of hepatotoxicity. And then adverse events, injection site reaction greater than placebo, constipation, particularly with arenumab for reasons that are not clear. It's the one that targets the receptor to CGRP, but still not clear why constipation is an issue. But I do co-manage a fair number of folks with significant constipation and GI motility issues that are seen here. So I'm cognizant of this, and typically, if it's depending upon the severity of the situation, I'm always trying to communicate well with GI docs. But if it's a significant problem, then I typically will avoid one of the monoclonal antibodies to CGRP because I just don't think that we know that much yet. And then upper respiratory tract infections may be slightly greater than placebo. But binding antibodies do occur, but they're not so far thought to have an impact on efficacy of the monoclonal antibodies, CGRP. And then there are no drug interactions. So that's kind of odd, right? Almost everything interacts with everything else. So, but these are monoclonals, and they are eliminated by the reticuloendothelial system. But they are not thought to significantly interact or compete with liver enzymes or anything like that. We have 3-year, and actually, since I made these slides, 4.5-year data now with arenumab, with sustained efficacy and benefit without emergence of new adverse events. Again, injection site pain is kind of the main thing. And then this is evolving. So our previous paradigm of the anti-drugs is now to the right, evolving into newer preventive treatments now with the monoclonal antibodies to CGRP. A whole different subject is neuromodulation. Neuromodulation being typically devices. And that's kind of a whole another kind of ball of wax. I'll leave that be. And soon we're going to be looking at maybe other targets. So possibly PACAP, which is pituitary adenylate cyclase activating protein, polypeptide, I think. Nitric oxide, orexin, strangely. So these are under development, if you will, and so we may hear those. The monoclonal antibodies to CGRP approved to date appear to be safe and effective in migraine prevention, as measured by mean monthly migraine days. Substantial numbers achieving even 50 or 75% reductions in migraine monthly days. Safety and efficacy also established in studies of refractory patients, so medication overuse or even tried up to 2 to 4 prior preventives. And then elimination is by reticuloendothelial system. All appear to have few to no drug interactions and few to no contraindications, although I'm always cautious with a new drug because you have a statistical phenomenon, right? So you have, in order to convince the FDA to get something approved, you have a few hundred patients. When you put that into a population of 12 to 15% migraine, then you have just a statistical situation where you have adverse events that can be sort of detected in phase 4 trials and things like that. So there's subtle differences between the monoclonal antibodies involving things like dosing interval, monthly versus quarterly, route of administration, sub-Q. The 3 so far approved are sub-Q, but 1 IV coming out later. And then site of action, so receptor versus ligand. Arenumab is the receptor, the rest are ligand. And there may be logistical differences on a more practical basis regarding availability on formularies, cost, support systems, loyalty programs, other pharmaceutical company shenanigans. So, this again is a little bit small print, but essentially, who should try one of the newer antibodies? I think certainly prior preventive treatment failures, or there may be situations in which, for example, a patient has multiple sensitivities to certain medications, or they have contraindications like prior kidney stones, for example, to trying topiramate, or complex pharmacology required to treat other complex medical conditions. Also a very small print. Sorry about that. So we're going to switch and talk about acute migraine treatment. So when I'm talking patients and to other doctors, I'm often using my hands, but acute treatment is what you take when you start to have a migraine. Preventive treatment is what you take for a while with the expectation of reduction in frequency, severity, or duration. Try to prevent migraine from occurring. So, what we've had up to this point have been relatively either non-specific or specific. So non-specific are, things that people have tried before seeing you. So things like acetaminophen and other NSAIDs, sometimes antiemetics, which of course are prescription, but they're not relatively non-specific. Now there is rationale for giving somebody dopamine, for example, for acute treatment of migraine. I'm sorry, not dopamine, compazine for acute treatment of migraine because of its mechanism of action on the dopamine receptor, but they're thought to be relatively non-specific with respect to addressment of the underlying pathophysiology of migraine. Relatively more specific medications, so the ergots, when I was a resident, for example, not only were there not headache fellowship programs, but there weren't triptans. What we had were ergots. Well, ergots work on multiple serotonin receptor subtypes, 5-HT1A through D, I guess, that are throughout not just the nervous system, but also throughout the GI tract. And so for those that treat inpatient status migrainosis, you know that you have to pre-medicate with an anti-nauseant because of the GI side effects of the ergots. Also, sort of reflection of longevity, one of the oral ergots, Sansert, which is a methotrexate, was taken off the market more than 10 years ago, but it was an oral preventive for migraine that was relatively effective, but had this odd adverse event of retroperitoneal fibrosis, pulmonary fibrosis, and possibly valvular fibrosis. So ergots, strangely, are still being studied, and there are inhaled ergots that are pending FDA approval. I'm very leery for, again, this concept of sudden statistical explosion in a larger population of problems that we may see with ergots. So I'm approaching those very carefully. But triptans, 7 different triptans, slight differences in half-life, onset of action, route of administration. But I think most of us are fairly comfortable with the triptans. The last one was approved in 2004. The first one was approved in 92, and I'm still a resident. But there have been lots of demonstration. The main contraindication is uncontrolled hypertension and/or coronary artery disease or accumulation of risk factors for development of coronary artery disease. So we use this with quite a bit of caution. But there's one Ditan that is pending approval by the FDA, and that's, it's actually been approved by the FDA, but not yet categorized with respect to the controlled substance category. It's probably going to be a Schedule 5, and that's lasmiditan. Trademark name now is Reval. It's co-promoted with Allergan. In October, it was approved, but it's pending, to my knowledge, the stamp of which DEA category it will be. Probably not highly addictive, but has this dizziness, which it's, we're neurologists, everything we have has some dizzy, drowsy, sleepy, drunk sort of thing. But anyway. And this is looking at the 5-HT1F receptor and kind of overlap between medications, the triptans and the ditans. So as you can see from the Venn diagram upper left, they're are a couple of other Ditans that are under investigation, but lasmiditan, the one that has so far been approved by the FDA, and we'll see when it comes out. But this is safety and efficacy for acute treatment of migraine versus placebo. Again, the placebo is in the blue, and these are 2 different doses. Looking at outcomes of pain-free at 2 hours following administration and MBS's most bothersome symptoms. So it turns out that if you poll a population of persons with migraine, photophobia, for whatever reason, is the most bothersome symptom statistically, but I think that varies from individual to individual quite a bit, and certainly in my population, it seems to be nausea more so than photophobia, but you do see the folks that have particular chronic migraine and walk around with sunglasses and what have you. And then, so the 2 different prospective randomized controlled trials, we have to give drug trials dual names now, so we have Spartan and Samurai, but different doses for lasmiditan, so in acute treatment of migraine. The Gepants, so yet another drug class status of approval. So earlier in 2019, the first was received the NDA and has since been approved by the FDA, and that's ubrogepant or Ubrelvy. And then the next one is has received the NDA but not yet FDA approved, and that's rimegepant, which doesn't yet have a trade name. Probably will come out in the second quarter of this year. And this is looking at for acute treatment of migraine. So rimegepant on the left and ubrogepant on the right. Again, they're looking at pain freedom at 2 hours and most bothersome symptoms. So the top graphs are pain freedom and the bottom ones are most bothersome symptom. But we see efficacy, but again, we kind of have this pretty high placebo effect. So in the very near future, we're going to have not only the specific treatments that we've had, but we're going to have different target receptors. And the Gepants are, of course, antagonists. The Ditan is an agonist, so we have to be slow and careful about our discussions of pharmacology. Cluster headache, I do want to mention that galcanezumab has been approved for prevention of cluster headache, cluster headache is a relatively much less common headache condition. It occurs 6 to 1 more commonly in males. But in the short term, what we've had are greater occipital nerve blocks with steroids, steroids by mouth, and then DHE, and then SPG blocks, phenylpalatine ganglion blocks. Phenylpalatine ganglion is the posterior nasopharynx, really blocks just V1 and V2 of the trigeminal distribution. But now we have galcanezumab. Long term, there have been basically verapamil, melatonin, and topiramate, but we may be seeing, invasive neuromodulation in some refractory patients, and certainly we see the refractory patients. The future therapeutic approaches, atogepant is another Gepant, which is undergoing phase 3 trial now for prevention, so a Gepant for prevention. And then PACAP, as I mentioned, pituitary adenylate cyclase activating polypeptide. And then the neuromodulation approaches, which are kind of a whole nother discussion, are probably going to be coming in the future. I think that's all I have, and I'd be glad to have a discussion or questions. Yes, sir.
Put the lights up. Dr. Sowell, I have a couple of questions to start out with. Epidemiologically, is it right that acute migraine is more common than chronic migraine?
Yes, that is correct. Okay. Yeah.
And you mentioned the GI tract a lot, and we have another electrophysiologist in the neurophysiologist, Dr. Ebell in the audience. So you're right There's a big gut-brain interaction. A lot of the drugs that we use are similar drugs and affect similar pathways. But they also, as you mentioned, cause a lot of problems. So, athletes that have intermittent migraines and take Imitrex end up needing to have a scope for their bloody diarrhea from their ischemic colitis. Cyclical vomiting syndrome and gastroparesis have big interactions. A couple of things you didn't mention, so they're probably not used anymore, is barbituates and diet. And so the diet thing, I don't know if it's people that don't comply with it, but you can put people on a migraine headache diet and it'll work if they really, really, really stick on that for acute migraine. So they're probably not the congenital CGRP, whatever that problem is. They're probably more HT related category. Correct? And what do you do with diet? Let's just start with that. Sorry about that.
So the diet's a big factor in everything neurology. And Dr. Rob Friedland, you get that idea. I think that diet is not as well studied as it should be. And that's probably true for every disease state, but it's certainly true in my disease state, which is migraine. I think that we have the general idea that excess caffeine, MSG, aged cheese, red wine, these are triggers.
Marbled meat,
things like that that are sort of passed down observational information, but not as well systematically studied, and I think that's a shame.
Nitrosamines, hot dogs, lunch meat.
Yes.
All of that.
No question.
You stop that, you won't get the acute migraines.
No question. And it's a paradoxical thing in some circumstances, right? So caffeine is a component of both over-the-counter medications and Fiorset. So then I'll start on the second question, is the butalbital. The Fiorset was, just trivia, developed at Montefiore. That's why it's FIOR, Fiorset. It was developed for tension-type headache in the 1970s. And for reasons that are absolutely unclear to me, started to be used for migraine and sort of thought to be good. Butalbital, so if I sedate somebody, their migraine gets better, right? So if no, they would never do this, but if I asked one of the anesthesiologists, put them under, their migraines are gone, right? So anything that's sedating can relieve a migraine, but that's not our goal as physicians. Our goal is to restore balance, life, back to work. Migraine is associated with reduced, not just absenteeism from work, but presenteeism, which is a concept of reduced productivity while at work. So if you have migraine while you're at work, you're not going to be able to concentrate as well or get things done or what have you. So I think that that needs to be kept in mind. But butalbital, I find, has almost no place these days in migraine with our other available.
I understand that
Not to my knowledge, not yet, but I think that may be coming. I think that maybe. So estrogen fluctuation, we know that take a population of women with migraine and examine the relationship to the menstrual cycle, then most migraines occur around the time of the menstrual cycle. But I don't really take the approach of sort of modulating hormones to make migraines better. I think that's a little bit down a rabbit trail. Yes. Sure, we don't know. That would be my comment. No, and I think that's probably going to come down the pike, right? Because fibromyalgia is comorbid with migraine. And, these are right. And certainly there's musculoskeletal pain associated with migraine, and then some individuals meet criteria for fibromyalgia, but I think that merits some systematic study so that we can answer. Yes. No, but again, this is a 12% to 15% of the population study, so that I haven't run across it in my reading the literature. I think that certainly it's an area that merits important study because we're making lifestyle recommendations on the basis of very little evidence, right? So it's the way we trained or what we observe or what we read, but not necessarily systematically collected evidence. And I think that's the type of, there's more of a push for drugs than there is lifestyle changes, essentially. And so I think that we need to, study these variables very carefully and then maybe make better recommendations.
Yes.
Thank you.
I'm curious about that response. So is anyone looking at what is?
Not to my reading, but yes, there's a lot more that I don't know than I do know. So I'm sure there probably is somebody looking at that on a basic science level, but it hasn't made it into the clinical realm yet. It's a very good question. Yes. No. In a word, no. So, and certainly those GeneSight and other branded panels are more skewed in the direction of psychiatry. Psych drugs, but not really neurologic drugs. So no, and I think these are brand new drug classes and new receptors that are very different. So, but I know some of those GeneSight panels look at serotonin and how does somebody metabolize serotonin, but I haven't found literature on correlating that with like the 5-HT1F or the triptans for that matter.
So most of the SS or tricyclics, that he listed that were useful for migraine have constipation as a side effect, and we use them in GI for diarrhea, predominant irritable bowel syndrome. So it doesn't surprise me that there's still a lot of the story behind the gut-brain axis, tricyclics as well as the serotonin drugs and receptors. And I mean, Dr. Sowell was honest, 83%, if I caught that, people stopped taking whatever they were prescribed because of either side effects or lack of long-term efficacy. So I think the GCRP stuff will actually change the paradigm quite a bit once we understand it more.
And we do have to watch closely for the constipation side effect. Initially, it was listed in the package insert when Arenamed was first approved, and then it's in the last months it's been upgraded to. There have been a few cases requiring hospitalization and one or two requiring surgical intervention of sorts. So I think that I'm pretty careful in whom I choose one of those, particularly if I'm managing with all in the GI group.
Other questions? Tough disease. Good presentation. Thank you.
Thank you.
Are you doing anything right now?